Okay, so this is a paper that Dr. Blum helped put together. I wrote this about 6 years ago, and he took it and made it a scientific paper. And it's basically the cranial dental model, what I've been teaching for the last 10 years, and the whole background to what, why, and how we treat, how the integration of the SOT in dentistry, and how I have integrated the two. So, craniofacial distortion patterns is what the term I've been using to try to create a standard, because in the dentistry, understanding what headgear effect was fundamentally the base of this. Headgear effect was from a seminar I went to in 2002, I think, and several of the dentists that are going to be here actually were there with me, and I looked at what they were talking about, and they were talking about craniofacial distortion patterns, and they called it the headgear effect. And I knew at that point I had to figure out what they were talking about and be able to explain it, because it didn't mean anything to us as chiropractors, it meant something to me, but I didn't know what to do with it. So this is a result of that. So, and it became not just the facial aesthetics. It wasn't the cranium that I was talking about. I was talking about the whole body, how the adaptation process ran through the whole body. How did we adapt, and how did we fail to adapt? And then underlying that was understanding growth and development. Growth and development became the key. The key was that we were not growing to a genetic potential, and that affected the entire kinematic chain. So it included both acquired and iatrogenic, meaning what Mother Nature or what we were doing with our poor nutrition and development, and what the dentists were causing. So pictures are worth 1,000 words. This is a headgear. And everybody knows somebody that had headgear or does have headgear. And this still goes on today. I just had a patient a month ago send in to me who had a bad back, kid, 14-year-old, and it was the headgear. So we had a little go around about taking it off. And so it's still here. It's still relevant. They still teach it. So headgear effect, the definition. It's an environmentally induced force on the maxilla and the maxillary teeth, resulting in the position of the maxilla or the maxillary teeth be retrognathic relative to optimal position, meaning where it should have grown, it didn't grow where it was supposed to. So it's the natural system out of balance. The biggest thing is this thing about orthodontics and not doing orthodontics correctly, that the orthodontics are contributing to or exacerbating a poor growth development pattern, which is fundamentally a vertical growth pattern versus a horizontal, which we'll see here in a second. So this is what our picture, cranial dental system, cranial system. And if you look at this is what it does. It grows more vertically and it grows down, so you get the longer, narrower face. The key being that it's an aberrant growth pattern. This is not normal, even though this has become the norm. I should say it's normal, it's not healthy. And the whole object in SOT is that we are treating the whole system. So what goes on above has reactions or compensations below. And understand that is a key, because that's how we treat, is understanding those reactions. So this guy said, cervical headgear treatment is class 2 correction is associated with a decreased facial convexity caused by the restriction of forward growth and maxillary A point. So this is just the dental definition. It really is just what the research is showing and just validating what I talk about here. So historically, the orthodontics approach tended to be focused on the belief that there are too many teeth or too big teeth. And the old thing was you got your father's teeth in your mother's jaw, which is really nonsense. It's really an erroneous statement, because genetics is genetics, and if you're expressing genetics properly, then everything should balance. So extraction of bicuspids or premolars to reduce crowding and make space. So in other words, you're reducing the size and shape of the dental arch by reducing teeth. So headgear effect, which is the dental definition, which is where this started, which is what I had been exposed to, describes the downward and backward growth of the oral facial structures, with or without the use of headgear. It happens naturally. It's the thing I realized. It isn't just caused by orthodontists. They're just taking a poor growth pattern and making it worse. So you understand that patterns of growth in SOT cranial trauma would be called craniofacial distortion, which includes the entire system, not just the face. So restricted or distorted growth patterns of the upper jaw, inhibiting normal growth patterns, restricting upper archway width and or length, inhibiting both proper growth of the craniofacial structures. The lower dentition will attempt to fit the shape of the upper dental arch. In other words, in dentistry, whatever the upper jaw does, the lower jaw has to respond or follow to. So if it stays in the class 2 normal, it's trapped by the upper jaw. The only time it doesn't work is if you get a class 3, and then you have the jaw sticking out. So this all started with John Mew, and this is the conference I went to. This is the one that was the eye-opener of what they were talking about, that there was a whole functional part of dentistry, that there were dentists that saw this and didn't know the rest of the body, but John Mew actually had talked to him, and he worked with osteopaths. He never worked with chiropractors. And he talked about his appliances and how he normalized growth pattern, and it was the same as an osteopathic manipulation. When he would have post-checks with osteopaths he worked with, he said everything would clear, the cranial rhythm would return, they would have responses that were very positive, meaning he knew that he was doing the right thing because he was getting validated from an osteopathic analysis. So he said that treating crooked teeth is treating symptoms, and that's why they relapse. The removing teeth would hinder growth and development. Maxilla is a secret to developing proper airway, jaw function, and cosmetics. The secret is this. He's saying maxilla is always the key. The malocclusion is related to the increased vertical growth. So the object is keep the maxilla up and forward. So the whole object is understanding what normal is, or what healthy is. Not what normal is, what healthy is, what a healthy maxilla and what facial structure is supposed to look like. So it was a growth guidance paradigm. So he was teaching how do you push the system to grow in a more normal, healthy way. So his whole thing was you develop the maxilla up and forward, and that you should start by the age of 8 years old, meaning you have a lot of growth left that he can guide with his appliances. So focus on expansion of the dental arch as a means to restore nasal airway and eliminate mouth breathing. So he knew back then that TMJ, dental arch, and airway were all the same problem. They were all functional losses. So when you bring the jaw forward and tongue forward, you open the airway. And the big thing for me is understanding that this whole craniofacial distortion pattern puts the body into sympathetic overload. Because of the distortion, because the body's not growing naturally, it's imbalanced. And when it's imbalanced, it has increased muscle tension, it has reduced airway, it has reduced pulse ox, it has all kinds of effects. So you get all these different things. So you'll get into these psychogenic stress disorders, meaning that the nervous system is out of balance. The autonomics aren't regulated properly. So it can be caused by orthodontics, or it can be stress. It can be psychological, it can be physical, but they overlap. Which is which? What's the priority? So are they sensitive or are they psychological? These cases tend to be more sensitive, and they appear to be psychological, and they get really diagnosed as psychogenic, and they're not. They're not. They're consistently, well, I shouldn't say 100%, but majority of them are not. They don't like being adjusted. They don't like standard chiropractic high-velocity adjustments. They have lower pain thresholds. And then this guy, Walland, had this study. Chronic TMD pain states in adolescents are accompanied by amplification of bodily but not purely emotional stimuli, and that cognitive systems are implicated in only alteration of the nociceptive. Very technical term, but same basic understanding. So going to another dental seminar, I realized how important this whole dental relationship is, because the arc of the jaw has the center of rotation at the dens, or C1. So this guy, Casey Gouze, did this, I think, in the 50s. And so fundamentally, it became the mechanics of how I looked at things. What was the relationship between the jaw and the neck? Well, if the jaw had the proper arc, didn't pop, didn't click, and was developed properly, the mechanics were all balanced, and it was at the C1, or the C1, C2, or the dens of the C2. So it's not inside the joint. This sliding, gliding joint does not have an arc in here. It's here. It is with the cervical spine, which means the cervical spine mechanics and the jaw are directly related. So that was a huge thing. So head posture and craniofacial distortion. So airway compromise and TMD relate to cervical spine. So the forward head posture. Classic forward head posture is traumatically induced in chiropractic, and 100% of the cases that we analyze are always forward head posture. They just don't show up without it when you have poor TMJ mechanics and airway. So that this is a functional adaptation, forward head posture. So when you look at this, the mandibular motion produces inferior pressure. So how does it do that? Because of the muscles and the way they pull. So everything pulls down. Transmit through the cranial sutures and the dural membranes via the temporalis masseter and the pterygoid muscles, which is part of this collapse. This is where the muscles start distorting or changing the system. So it leads to sleep apnea, the open mouth breathing, and then you get into the bruxing and grinding as part of the adaptation because the body's out of balance. So mouth breathing is supposed to be tongue rest, is the rest position on the roof of the mouth. So it requires lip seal and nasal breathing. Lip seal and cheeks match the pressure from the tongue to maintain healthy growth, which means the pressure inside the mouth matches the pressure outside, which is what maintains your dental arch. One of the things that I think is 2 grams of pressure to move a tooth. So when you remove the tongue, or the tongue sits down in the lower jaw, now you have that 2 grams of pressure. So now why do teeth collapse? Why do we have an 88% failure rate in orthodontics? Because they're not looking at the mechanics of the system. And the 88% failure is their data. They're admitting to an 88% failure rate, and it's the patient's fault for not running the retainers, which this explains it's not their fault. The orthodontists are not looking at the system, not balancing the system. So this collapse inward, downward, and backward happens when the tongue doesn't push up and out on the arch, resulting in the narrower arch, the palate becoming higher, and restricting the expansion anteriorly or laterally of the arch, thus producing this vertical growth. So now you get craniofacial suture tension, get into this trigeminal nerve irritation, and then changing posture and compensations throughout the musculoskeletal system. So, and the SOT approach, or the whole body analysis, what changes? You're reducing the flexion phase of the cranial rhythm. If you narrow the head and look at the pictures of what flexion extension is, if the head's restricted and it's narrowed, it's elongated, it can't go into the extension phase physically. It's been restricted. It's been anatomically put in a position of stress. It has to change or adapt. So it reduces the CSF and the CRI, promotes cranial extension restrictions and faults. So we end up, why do we have SP plus faults? When you do an SOT analysis, 99+% of the patients are SP plus because they're in this cranial extension. And all the TMJ patients, 100% of them are like this. This is absolutes. Reducing the return of CSF because it reduces the sacral movement, so it affects the whole system. So then you get this depressing parasympathetics and increasing sympathetic stimuli, resulting in increased muscle tension and guarding, forward head posturing, and the same compromise in the mouth. So again, the reaction and compensation to this distortion or to the primary lesion or compromise is loss of cervical curve, increased forward head posture, increased tension, cervical musculature, suboccipital tension, TMJ and craniomandibular disorders, which is what I explained earlier. And you have increase or decrease of lumbosacral angle. In other words, there's adaptation that the body's starting to fail because it's altering posture all the way down to the low back and even down to the feet. So you have loading or pressure on the sacroiliacs and compromise or a lesion or adaptation that happens in the sacroiliac and all the way down to the feet, metatarsals, and foot mechanics. So muscle tension is present in all those places. So in the integrative therapy part, now it's a whole body analysis. You have to look at how this manifests. What are the symptoms? So primary, start with the sacroiliac, the weight bearing. You're looking at the category 2 and the category 1 type lesions. So then you're looking at the craniofacial mechanics related to TMJ and how to undo orthodontics or redo them so you support normal growth and development and balance the nervous system. And then posture becomes a key. If I do not improve posture, if we do not reduce forward head posture, improve cervical curve, and their ability to stand straight, then this is a failed case 100% of the time. Posture has to improve. Part of this that's been added to our model is using this oral myofunctional therapy. Because of the dysfunctional muscle patterns in the mouth, block orthodontic change, can alter TMJ function. It was one of the ceilings I hit a couple years back that I couldn't figure out why we weren't getting results, and what it is that it was the tongue and the myofunctional habits of the mouth. So you have to re-educate the muscles in the oral facial cavity. Another historical perspective, I had this book from the time I got out of school and never really understood how it applied to us until I looked at this model. And then this whole compromise of growth and development was the same thing in cats. Pottinger was an MD back in the 40s right here in Monrovia, California. So his book had a lot of detail about this and how he fed cooked food versus raw food. And he quantified changes in growth and development over multiple generations. And the same thing we see in humans, he saw in cats: loss of hair, enlarged organs, hostile temperament, common homosexual behavior, inability to reproduce, facial structure distortion, and loss of teeth in these animals when they were off their normal diet. Raw food did not produce that at all. And then he also did this. This was the other big key when I started looking at this, that he found that the type of biomechanical stress to the tarsal and metatarsal bones resulted from recurrent metabolic insults. So disturbances in the growth of the skull, notably the malar bones and the mandible, usually takes place at the same time as corresponding bones of the foot. Now, he doesn't mention the maxilla, but if you have distortion in the malar bones and the mandible, you have to have aberrant growth and development in the maxilla. I mean, this goes together. So now he's saying the face and the feet go together as far as breakdown, which is absolutely 100% true. I mean, it tests out all the time. You have to look at foot mechanics. Then you have Weston Price, which everyone knows this, it's the same thing. Facial distortions, tooth decay, airway compromise from processed food. So meaning that's where it comes from. That what sets us up is what we eat, what we feed our kids. So system care versus symptom care. I did symptom versus symptom. So it's a matrix of structure and function, the dental growth and development, airway, autonomic nervous system balance, and integration, so that you're treating the whole system comprehensively. So treatment has to be inclusive of many specialties. It's like we've added the oral myofacial people in because retraining the tongue and the oral cavity is a huge part of it. Craniofacial growth and development, and analyzing the CRI. If you're not normalizing or balancing the CRI and the cranial rhythm, you're not going to have a good result dentally. Snoring and sleep apnea is the 800-pound gorilla in the room. If they're not breathing right, you're never going to fix them. Upper airway resistance syndrome is a non-snoring, not really a sleep apnea, but has interruptions and doesn't function right because your airway is too restricted, but it's less distortion, less pathology, less noticeable. And calming the sympathetic overdrive becomes a huge part of this. If you do not slow down the sympathetic guardian pattern, you don't fix anything because they will fight with you all the time. I think that's it. Okay.
Thank you. Thank you.
Body, how the adaptation process ran through the whole body. How did we adapt and how did we fail to adapt? And then underlying that was understanding the growth and development. Growth and development became the key. The key was that we were not growing to a genetic potential, and that affected the entire kinematic chain. So it included both acquired and iatrogenic, meaning what Mother Nature or what we were doing with our poor nutrition and development, and what the dentists were causing. So pictures are worth 1,000 words. This is a headgear. And everybody knows somebody that had headgear or does have headgear. And this still goes on today. I just had a patient a month ago send in to me who had a bad back, kid, 14-year-old, and it was the headgear. So we had a little go around about taking it off. And so it's still here. It's still relevant. They still teach it. So headgear effect, the definition. It's an environmentally induced force on the maxilla and the maxillary teeth resulting in the position of the maxilla or the maxillary teeth be retrognathic relative to optimal position, meaning where it should have grown, it didn't grow where it was supposed to. So it's a natural system out of balance. The biggest thing is this thing about orthodontics and not doing orthodontics correctly, that the orthodontics are contributing to or exacerbating a poor growth development pattern, which is fundamentally a vertical growth pattern versus a horizontal, which we'll see here in a second. So this is what our picture, cranial dental system, the cranial system. And if you look at this is what it does. It grows more vertically and it grows down, so you get the longer, narrower face. The key being that it's an aberrant growth pattern. This is not normal, even though this has become the norm. Or I should say it's normal, it's not healthy. And the whole object in SOT is that we are treating the whole system. So what goes on, because in the dentistry, understanding what headgear effect was the fundamentally the base of this. Headgear effect was from a seminar I went to in 2002, I think, and several of the dentists that are going to be here actually were there with me, and I looked at what they were talking about, and they were talking about craniofacial distortion patterns, and they called it the headgear effect. And I knew at that point I had to figure out what they were talking about and be able to explain it, because it didn't mean anything to us as chiropractors, it meant something to me, but I didn't know what to do with it. So this is a result of that. So, and it became not just the facial aesthetics. It wasn't the cranium that I was talking about the whole Okay. So this is a paper that Dr. Blum helped put together. I wrote this about 6 years ago, and he took it and made it a scientific paper. And it's basically the cranial dental model, what I've been teaching for the last 10 years, and the whole background to what, why, and how we treat, how the integration of the SOT in dentistry, and how I have integrated the two. So craniofacial distortion patterns is what the term I've been using to try to create a standard